Hello everyone, I'm Jing, and let's continue our journey on part 2 of venous thromboembolism in pregnancy and puerperium. Thank you everyone for staying with me. We have learned what is VTE, the overview, and risk assessment from pre-pregnancy to postpartum period. We have also visited both pharmacological and non-pharmacological thromboprophylaxis. Now, let's continue our journey to the next destination, which is diagnosis of VTE and pulmonary embolism, followed by contraception. Venous thromboembolism is a condition that occurs when a blood clot forms in a vein. It includes deep vein thrombosis and pulmonary embolism. DVT is a condition in which a blood clot develops in the deep veins, usually in the lower extremities. A pulmonary embolism occurs when a part of the DVT clot breaks off and travels to the lungs. For deep vein thrombosis, patients usually present with unilateral swelling of limb, claudication pain, or heavy ache in the limb. On examination, you would notice swelling of the affected limb with increased warmth of lower limb, reduced capillary filling, and fever. On the other hand, patients with pulmonary embolism would typically present with sudden onset of shortness of breath, chest pain which is dull and worsen on inspiration, and also non-productive cough which is occasionally blood-stained. On examination, they would appear tachypneic, tachycardic, cyanosis, and in worst-case scenario, they will have cardiorespiratory compromise or sudden collapse. Coming to investigation, patients who are suspected of DVT will also need to be monitored on pulse oximetry and have blood investigations like full blood count, renal profile, liver function test, and coagulation profile done. Compression duplex ultrasonography is the modality of choice to diagnose DVT, and focus should be placed on the iliofemoral and popliteal vessels. For venogram, although this is the gold standard, it is associated with radiation risk and hence is rarely utilized in pregnancy. On the contrary, pregnant and postpartum mothers who clinically present with pulmonary embolism will need to have arterial blood gas done, along with chest radiograph and ECG for further assessment. Chest X-ray is done to rule out other conditions like pneumonia, which would present similar to pulmonary embolism. Most of the time, ECG would show sinus tachycardia as S1Q3T3 are rarely seen in pregnancy. In severe cases, right axis deviation, right bundle branch block, and peak P wave in lead 2 may be evident. The gold standard to diagnose pulmonary embolism is CT pulmonary angiogram or lung ventilation perfusion scan. Both involve very low dose of ionizing radiation, but the benefits of performing this test far outweigh the risks. Any pregnant or postpartum patients who are suspected to have VTE or pulmonary embolism should be coded red and referred immediately to the nearest hospital. Remember, this is an obstetric emergency. They should be sent to the nearest hospital accompanied by an appropriately trained staff. This should be a medical officer where possible. If an obstetric retrieval team is available at a nearby hospital, this retrieval team should be optimized. It is also important to stabilize the patient prior to transfer. If anticoagulant drug is available at a health facility, the first dose of anticoagulant should be given by the attending doctor prior to transfer. It is not necessary to wait for the diagnostic scan to confirm the diagnosis, as this is an obstetric emergency. During transfer, the following equipment should be available. Firstly, vital signs monitor including pulse oximeter. Secondly, oxygen and high flow mask. Lastly, equipment and drug for maternal resuscitation. It is vital to make sure all these are available in the ambulance as patients' conditions may deteriorate at any point of time during the transfer. Now let's look at the choices of contraception. Women who have a higher risk of VTE or with a history of VTE should avoid combined hormonal contraception, either in oral or injectable forms. This is because it has been well established that estrogen increases the risk of both arterial and venous thrombosis. Studies have shown that the use of combined contraceptive pill is associated with a risk of VTE of 15 per 100,000 women years as compared to 5 per 100 women years in non-users, which is 3 times the risk. Therefore, non-estrogen containing contraception should be offered to this group of patients. First of all, copper intrauterine device is suitable to be used in patients at risk of VTE, as it does not pose additional risk to thrombogenic event. It is hence categorized as Category 1 in WHO's medical eligibility criteria. It can be used once the uterus has returned to normal size. Apart from that, progestogen-only contraceptions are safe. They are categorized under MEC Category 2, which means that the advantages of using this method generally outweigh the theoretical or proven risk. Examples include the oral route, which is progestogen-only pill. Secondly, depot medroxyprogesterone acetate and noradisтерone via intramuscular route. And thirdly, the levonorgestrel implant. Lastly, barrier methods are safe as well. In short, we should tailor choice of contraception individually based on their medical conditions and preferences. The WHO medical eligibility criteria for contraceptive use is a great tool to use during counseling and decision making. This is the end of our journey in VTE. Thank you for joining the ride. These are my references. Now, shall we do some case discussion? You may want to grab a pen and a piece of paper to write down your answers. First case. A 36-year-old lady, para 5, is a known active smoker who takes more than 10 cigarettes per day, with booking BMI of 25.2 and no other significant personal or antenatal history. During delivery, she had postpartum hemorrhage, losing 1.2 liter of blood. First question. What were her VTE risk factors and what were her risk scores? You may write down your answers now. Question number 2. Would she require thromboprophylaxis? If so, when and for how long? Please write down your answer. Now let's look at the answer. For this patient, her smoking status of more than 10 cigarettes per day and postpartum hemorrhage of more than 1 liter are the risk factors for VTE. Hence, her VTE risk score is 2. During postpartum period, a VTE risk score of 2 calls for thromboprophylaxis and the duration is 10 days. Do you get your answers right? Unfortunately for her, she was not started on thromboprophylaxis back then. She had been complaining of left lower limb swelling and pain since postpartum 1 week, and thus went to a nearest health clinic. However, she was dismissed as having musculoskeletal pain. She subsequently went to a private clinic twice without any improvement. On postpartum day 24, she went again to the same health clinic and was seen by the same doctor with complaint of worsening leg symptoms. Once again, she was dismissed with painkillers and reassurance. What are the signs and symptoms that should draw your attention to the diagnosis of DVT? Patients complains of leg pain and fever, and on examination, the difference in calf circumference, unilateral leg swelling, increased warmth of the affected limb should prompt a diagnosis of VTE. 5 days later, on postpartum day 29, she went to the emergency department of a nearest hospital with worsening leg swelling and pain, with additional complaint of shortness of breath and chest pain. A clinical diagnosis of left DVT with possible pulmonary embolism was made, and treatment with low molecular weight heparin was commenced before any imaging tests were done. Venous Doppler study reviewed long segment DVT of left lower limb with inferior vena cava extension. CTPA reported thrombosis of the left descending pulmonary artery with pulmonary infarction. Subsequently, she recovered well with low molecular weight heparin. Do you agree with the management above? Think about it and write down your answer. The answer is yes. This is an obstetric emergency. Treatment should be initiated as soon as possible if the diagnosis is probable, without waiting for further investigation. For this patient, how will you manage her next and subsequent pregnancy in terms of VTE risk? And what are the lessons learned from this case? For her subsequent pregnancy, she will have very high risk of getting venous thromboembolism. Hence, she will need to be started on thromboprophylaxis from first trimester itself and to continue for 6 weeks postpartum. This case showed the importance of VTE risk assessment for obstetric patients, be it during antenatal or postpartum period. Her VTE risk score of 2 calls for postpartum thromboprophylaxis for 10 days. If it was administered as indicated, we could have prevented the incidence of DVT and pulmonary embolism. Let's move on to the second case, which is in fact a maternal mortality case. This was a 34-year-old lady, G3 para 2, at 9 weeks of gestation, with booking BMI of 23. During her early pregnancy, she had a total of 5 visits to private clinic. The first visit was for confirmation of pregnancy at 8 weeks gestation. The subsequent 4 visits were for excessive vomiting in pregnancy. During her third visit, it was noted that she had very poor oral intake and was tachycardic with pulse rate of 114 beats per minute. Hence, she was given a referral letter and was advised to go to the hospital for hydration and management of hyperemesis. However, patient defaulted and did not go to the hospital. At her 5th visit, the doctor noted that she was absolutely unable to tolerate orally, along with urine ketone 3+. Her BP was 90/60, with pulse rate of 112 beats per minute. Clinically, she appeared dehydrated. She was referred again to hospital for admission. She was hospitalized for 3 days and subsequently discharged home. Throughout her stay, it was noted that she was persistently tachycardic despite given fluid replacement. Her urine keto remained 3+, but in view of improved oral intake and patient insisted to go home, she was discharged. Question: did she have any risk factors for pulmonary embolism? What were her risk factors? Next, would you start her on thromboprophylaxis? If yes, how? Now, let's look at the answer. This patient had hyperemesis gravidarum, and this carries VTE risk score of 4. With this score, she should be referred to hospital for hyperemesis gravidarum management and to be started on pharmacological thromboprophylaxis, daily subcutaneous low molecular weight heparin until resolution of symptoms. Unfortunately for this patient, VTE thromboprophylaxis was not given as indicated. She collapsed at home and it was later found that she had pulmonary embolism. I hope everyone is now well aware of the importance of VTE risk assessment and thromboprophylaxis in pregnancy and puerperium. Thank you for your attention.